I'd now like to invite Bridget and Joseph to the stage to talk on starting point. Thank you.
Thank you, Ashley and Avi. Let's move from St. John's to Nassau County and starting point behavioral. I'd like to start with a story to help illustrate the idea, the need, and the hope to reinvent the way we think about the opioid epidemic in healthcare. Ned grew up with a mother who struggled for years with addiction. As a child, he never knew when he would see his mother again or what condition she would be in when he did. Ned began using drugs and alcohol recreationally at the age of 15 and developed an opioid use disorder after being prescribed them after an injury. Because of this, his life continued to deteriorate, and after several arrests, tried to take his own life by intentionally overdosing, but it did not work. Ned woke up hours later, horribly nauseated, under the bright lights of a hospital emergency room, with a nurse who said, "Ned, you overdosed again. You need to get help." Later that same day, Ned was released with a piece of paper recommending treatment. He imagined seeking treatment. He wanted to get better, but at this point felt overwhelmed with the idea of grappling with the most basic tasks. The complexity of navigating the healthcare system and arranging his own appointments was simply formidable. How many medical professionals had told Ned that he needed to seek help, but he felt ill-equipped to do so. With his growing doubt about his ability to get help and increasing dope sickness, Ned recidivated, or turned to his only sure fix, and recidivated in a hospital 2 weeks later in Jacksonville. The story of Ned is not uncommon. Over 130 people died to opioid-related overdoses nationally at the rate of 21 per 100,000. In the state of Florida, it increases to 24, and in Nassau County, increases to 29. And for every fatal overdose, there are more close calls. The Nassau County opioid epidemic continues to rise with its costs. At Baptist Hospital, the average cost of addressing drug and alcohol dependence without treatment, meaning stabilization, was reported to be $21,313. And in our data set alone, this accounts for over $8 million spent in drug-dependent stabilization in less than 2 years. The need for preventative services has become increasingly critical. So what could have gone differently in Ned's story to help prevent against and predict for his relapse? First, Ned needed assistance finding treatment and making that first step. Starting Point recognizes this need, and for roughly 2 years has offered care coordination to help increase treatment enrollment. This is accomplished by identifying barriers to care, helping clients find treatment through personal interactions and problem solving, as well as on occasion even driving clients to their appointments. This is care coordination prevention. The second component is prediction. Starting Point needs creative ways of investigating the factors that are most significantly correlated with recidivism to help complete their strategy of care. And let me introduce Joseph to tell you more about that.
Thanks, Bridget. To this end, we analyzed data from Starting Point's care coordinators at Baptist Hospital Nassau, the Mental Health Resource Center, and the county jail. This data describes the journey of an individual from the moment they are stabilized and referred to Starting Point until they either enroll in services or discontinue them. The data set we have contains information on 1,046 referrals for 878 clients. The data set goes back to February of 2018. Within this time frame of about a year and a half, about 13% of that population has recidivated. The types of variables we have include personal information such as the age and gender, the referral information such as the source and the date, and also more incidental information which is in the form of notes taken by the care coordinators at the scene. Our data preparation process began with merging and cleaning. We merged the 3 main data sources into a single data set and proceeded to clean the outliers, clinkers, and typos. I'm understating the amount of time spent here, but let's move on to the more important things. Interestingly enough, we used feature engineering on the notes taken by the care coordinators to extract more information about the individual. We used text mining techniques to gain features for homelessness, substance abuse, alcoholism, and more. We used keywords to extract indicators for these variables. For instance, mentions of keywords like DUIs and heavy drinking mapped to indicator variables for alcohol. After we had the feature engineering, we aggregated the data set. Since we wanted to conduct our analysis at the patient level, we needed to aggregate the multiple referrals for the recidivists. This entailed aggregating the time-sensitive information, such as the average days between referrals and the average time in care coordination. Moving on to the data analysis. In accordance with Starting Point's goals for this project, we wanted to understand and model the recidivist population. To do so, we used several predictive models to try and understand this population. But given the small amount of data we had and the problem with imbalanced classes, these models did not generalize well. Moving forward, we used descriptive models so that we could further understand the data we had. Descriptive models give us which features distinguish the recidivist population from the non-recidivist population. The results of this analysis are these main features. As you can see here, in order of importance from left to right, these features are indicative of recidivism and distinguish that population from non-recidivist population. For facility length of stay, we found that this population on average spends 6 days less in facilities. A facility in this case could be the jail. Followed by that, we see location. There's a major theme in location towards recidivism. It's more towards the East Coast and specifically towards the North Fernandina Beach region. Followed by that, we can see Baker Acts, which are involuntary hospitalizations, substance abuse, and medically assisted treatment. We found that these variables were twice as prevalent in this recidivist population. Since within this recidivist population, we also wanted to look at the recidivist population that did so within 30 days. This is an important number for reimbursement purposes for these institutions. We did a similar analysis and found the results here. As you can see, similarly, in order from left to right, the most important was by far location, again following the same trend of the eastern side towards North Fernandina Beach. Following that, we see time. Time in this case means the amount of time an individual spends in care coordination. This is distinguished by less time in care coordination. So people who recidivate within 30 days spend less time in care coordination, which means they derive outcomes sooner than those who do not. Followed by that, we see connection. This is one of the variables we extract from the text, determining whether a care coordinator had actually visited the person in question, either in facility or at home. Followed by that, we see pain. This is also one we extracted from the text, and it's interesting in that it's 3 times as prevalent in this recidivist population. These variables can help care coordinators address these concerns when they meet the individuals and drive insight into treating these individuals. Since location was such an important factor for both populations, let's take a closer look. As you can see here, this is a density map of all referrals within Nassau County within the last year and a half. You might notice that there's a trend towards the eastern side, the more urban areas. Now let's see if this density maps to the referrals as well, the recidivist referrals. This map shows the recidivism, and it follows the same exact trend. Now we thought this might be due to population alone, so we referenced the census tract numbers for population and normalized by population. Once we normalized by population, we found that these regions still have higher rates of recidivism with respect to their rural counterparts. Visualizing this information can enable care coordinators to drive preventative programs in these areas and address the communities as distinct entities. Thank you.
While investigating the individual factors of recidivism, we noticed a trend, that these recidivisms weren't happening in isolation. What you're looking at is a community network map outlining the movement of recidivism in between institutions. The circles on the outside represent the institutions, and the corresponding numbers in their arrows represent the patients received. Arrows looping back inward to the institution represent that individual organization's recidivism rate. Converting percentages, we can see that Baptist has a recidivism rate of 14%, MHRC 16%, and the jail 18%. This is the current way of understanding recidivism, but institutions are both receiving and sending. For example, Baptist received a total of 383 patients, but 14 ended up at MHRC, and 8 ended up at the jail. Historically, the individual focus of organizations has limited their ability to acquire the full picture. and then therefore solve large problems. But when considering our map, it's natural to see that recidivism doesn't happen in isolation and rather touches on multiple community facets. This suggests that when solving the opioid epidemic, prioritizing communication and community alliances is key. Applying this information, Starting Point has the opportunity to reduce the numbers corresponded with incoming arrows by tracking the flow of recidivism. Equipping decision makers and coordinators with this influential information can help shape future data collection, can allocate limited resources better, and direct services to the most relevant locations to create the highest impact. Acknowledging the mission and value of care coordination, Nassau County has the opportunity to stop problematic opioid use for people like Ned before it happens. Fortunately for Ned, his story did not end with an overdose. After revival, he came in contact with a care coordinator who promptly helped him arrange appointments, contact doctors, and even set up transportation all before he went home. Later that night, he thought about his future, and after talking to his care coordinator who helped direct him to the path of recovery, not simply suggest it, he looked at his future and for the first time in a while felt hopeful it could change. Thank you.